This is because of grinding the teeth when they were high. I'll finish this video by talking about marijuana, which most people call pot. It derives from a plant called cannabis. People usually smoke this drug, and the psychologic effects are from a component of marijuana called tetrahydrocannabinol, or THC. It's also called dronabinol. This substance can stimulate receptors in the central nervous system called cannabinoid receptors, and when they do, it leads to the effects of marijuana. These include a sense of euphoria, increased appetite. If you've ever met people who have been smoking pot, they're usually starving and gobbling down food, ataxia, slurred speech, impaired judgment, and impaired cognition. Rarely it can cause anxiety or panic attacks, but usually patients have a sense of euphoria and are more mellow after smoking pot. There are synthetic cannabinoids that are available for medicinal purposes. These are pharmaceutical forms of THC or dronabinol. They're available in capsule form, and they can be prescribed to patients for 2 FDA-approved usages. The first one is chemotherapy-induced nausea and vomiting. This often helps patients who have severe symptoms related to chemotherapy. The second one is for appetite stimulation. Remember, I told you that people that smoke pot often get very hungry, so you can administer synthetic cannabinoids to stimulate the appetite in people who have wasting illnesses. This is classically used for patients with end-stage HIV and AIDS. They can lose their appetite and become emaciated, and you can use synthetic cannabinoids to stimulate the appetite and to help them gain weight. And that concludes our video on other drugs of abuse. Hello, everyone, and welcome to our module on antidepressants. There are a lot of medications that are used to treat depression, and an easy way to keep them straight in your mind is to break them down into 5 groups, which we'll go through in this video. First are the tricyclics, then the MAO inhibitors, then the SSRIs, the SNRIs, and then finally some others which don't really fit into one of the other categories. Before we get into specific antidepressant drugs, let's talk about some general principles of depression. Depression is associated with decreased activity in the central nervous system of certain neurotransmitters, in particular serotonin, norepinephrine, and dopamine. And patients with depression can have improved symptoms if you boost the activity of these neurotransmitters in the central nervous system. And that's how most antidepressants work. They increase the levels and the activity of these 3 neurotransmitters. There are basically 2 ways by which most antidepressants do this. Either they block the reuptake of the neurotransmitter in the synapse. This leads to higher levels in synapses, or they inhibit the breakdown of the neurotransmitter so that higher levels will be present. So here's my own drawing of a synapse in the central nervous system, and we have a presynaptic neuron that is going to release a neurotransmitter into the synaptic cleft, which will then exert its effects on the postsynaptic neuron. The way that most neurotransmitters work is either by blocking the reuptake of the neurotransmitter or by inhibiting its breakdown. Either of these mechanisms will boost the levels of neurotransmitter in the synapse and increase the activity level of that neurotransmitter in the brain. Now let's go through by inhibiting our transmitter into the synaptic cleft, which will then exert its effects on the postsynaptic neuron. The way that most neurotransmitters work is either by blocking the reuptake of the neurotransmitter or by inhibiting its breakdown. Either of these mechanisms will boost the levels of neurotransmitter in the synapse and increase the activity level of that neurotransmitter in the brain. Now let's go through the 5 different groups of antidepressants. We'll start with the tricyclic antidepressants. These drugs are called tricyclics because their chemical structures contain 3 rings. For example, at the bottom of the screen are the chemical structures of nortriptyline, imipramine, and amitriptyline. Those are all examples of tricyclic antidepressants. These are old antidepressants that came on the market in the 1970s, and they're rarely used to treat depression in the modern era. The way they work is by blocking the reuptake of serotonin, which is also called 5-hydroxytryptamine or 5-HT, and also the reuptake of norepinephrine. So by doing that, they boost the activity level of these 2 neurotransmitters in the brain. The problem with these drugs is that they have very broad spectrum effects on a number of receptors. They block the effects in the brain of histamine, they can block muscarinic receptors, and also alpha-1 receptors. And because of these effects here, they have many, many side effects, and that's why they're not used much in the modern era. For example, their antihistamine effects often lead to sedation and wakefulness. The problem with these drugs is that they have very broad histamines that came on the market in the 1970s, and they're rarely used to treat depression in the modern era. The way they work is by blocking the reuptake of serotonin, which is also called reuptake of the neurotransmitter. 3 rings, for example, at the bottom of the screen are the chemical structures of nortriptyline, imipramine, and amitriptyline. Those are all examples of tricyclic antidepressants. These are old antidepressants that came on the market in the 1970s, and they're rarely used to treat depression in the modern era. The way they work is by blocking the reuptake of serotonin, which is also called 5-hydroxytryptamine or 5-HT, and also the reuptake of norepinephrine. So by doing that, they boost the activity level of these two neurotransmitters in the brain. The problem with these drugs is that they have very broad spectrum effects on a number of receptors. They block the effects in the brain of histamine, they can block muscarinic receptors, and also alpha-1 receptors. And because of these effects here, they have many, many side effects, and that's why they're not used much in the modern era. For example, their antihistamine effects often lead to sedation and weight gain, and if you give these drugs to elderly patients, they often become confused. By blocking cholinergic or muscarinic receptors, patients can develop blurry vision, constipation. Dry mouth was a big problem. Patients used to take these drugs, used to be thirsty all the time, and in addition, they could develop urinary retention. And then through alpha-1 blockade, patients who took tricyclics would often have orthostatic hypotension. You can break tricyclic antidepressants down into two groups, the so-called tertiary amines and the secondary amines. The tertiary amines have a nitrogen with 3 attachments. If you look at the bottom of the screen, imipramine is a tertiary amine. This is the nitrogen group here, and it's got 1, 2, 3 attachments. Therefore, it's a tertiary amine. Drugs in this class include imipramine, but also some of these others I've written here, like two groups, the so-called tertiary amines and the secondary amines. The tertiary amines have a nitrogen with 3 attachments. If you look at the bottom of the screen, imipramine is a tertiary amine. This is the nitrogen group here, and it's got 1, 2, 3 attachments. Therefore, it's a tertiary amine. Drugs in this class include imipramine, but also some of these others I've written here, like amitriptyline, clomipramine, doxepin, and trimipramine. And the thing about these drugs that you need to know is that they tend to be more sedating. They tend to have more histamine effects. So years ago, when these were the most commonly used antidepressants, if a patient had trouble sleeping, their doctor would often prescribe a tertiary amine because it was sedating. The secondary amines have nitrogens with 2 attachments. So nortriptyline is a secondary amine, and it has a nitrogen here with only 2 attachments, not 3. So examples of secondary amine tricyclic antidepressants are desipramine, nortriptyline, and protriptyline. And these tended to be more activating. They had more norepinephrine effects. So you would give a secondary amine to someone who had trouble staying awake during the day and felt very fatigued. The problem with tricyclic antidepressants, in addition to the side effects, is that when they're used to treat depression, if patients become suicidal and overdose on these drugs, they're potentially fatal. All of the things I've listed on this slide can occur among patients in the setting of a tricyclic antidepressant overdose. First of all, patients can develop seizures and potentially coma. That's because at high dosages, tricyclics antagonize GABA receptors in the brain. These drugs also block cholinergic receptors, so they can cause anticholinergic toxicity. So when you block cholinergic receptors, you can't sweat. And when you can't sweat, you can't dissipate heat, so you get very hot. So hyperthermia develops, and people with anticholinergic toxicity develop a fever. When your temperature starts to go up, your body dilates the skin, so these people have skin flushing. In addition, the pupils will dilate. That's because you're blocking cholinergic receptors. And then in the gut and in the bladder, you can develop ileus and urinary retention. These are all classic features of anticholinergic toxicity, and they can occur in patients who overdose on tricyclic antidepressants. And then finally, because of alpha receptor blockade, hypotension can develop, and this is a major cause of death. In addition, the QT interval on the EKG can prolong, and this can lead to arrhythmias. If you ever end up treating a patient with a tricyclic overdose, and I've had to do this once in my career, you will admit them to the ICU for close monitoring. What you want to monitor is the ECG for increased QRS interval. This is the most prominent manifestation of toxicity, and this occurs because tricyclic antidepressants at high dosages can block cardiac sodium channels. So when these patients are in the ICU, you put them on telemetry and you regularly check EKGs to make sure that their QRS interval is not becoming prolonged. The treatment for tricyclic overdose is infusion of sodium bicarbonate. This has two effects. The sodium in the infusion overcomes the tricyclic antidepressant sodium channel blockade in the heart, and this helps to reduce the chance of arrhythmias. In addition, sodium bicarbonate raises the pH because it's a base, and this favors the inactive form of the drug, so it will exert less effects on receptors in the body. Now, as I told you before, tricyclic antidepressants are rarely used in the modern era to treat depression, but they do have a number of non-depression uses that you may still see clinically. Clomipramine is a tricyclic antidepressant that is sometimes used to treat obsessive-compulsive disorder. There are two tricyclics, amitriptyline and desipramine, which can be used to treat diabetic peripheral neuropathy. Patients who have chronic pain syndrome sometimes see improvement of their functioning and overall pain level with a number of tricyclic antidepressants. All the ones I've listed here on the slide can potentially be used. Amitriptyline is sometimes used to prevent migraine headaches. Children who have bedwetting, which is called enuresis, are sometimes treated with tricyclic antidepressants because remember what I told you before, they cause urinary retention. They're not first-line therapy. The first-line therapy is desmopressin, which is an ADH analog. But if desmopressin doesn't work or the patient can't take it, there are a number of tricyclic antidepressants that are sometimes used. And then finally, as I told you before, some of these drugs are sedating, so they can be used for insomnia. The one that's usually used for this purpose is called doxepin. Moving on, let's talk about our second class of antidepressants, the monoamine oxidase inhibitors, or MAO inhibitors. As their name implies, these drugs inhibit the enzyme monoamine oxidase, and when this enzyme is inhibited, there is less breakdown of monoamines. So what are monoamines? Well, it turns out many neurotransmitters in the brain have a chemical structure called a monoamine, which includes a benzene ring attached to an amine group. Norepinephrine, dopamine, and serotonin, which is also called 5-HT, are all examples of monoamines. So when you inhibit monoamine oxidase, you get less breakdown of all three of these neurotransmitters and therefore higher levels in the brain of serotonin, norepinephrine, and dopamine. There are two subtypes of the MAO enzyme. MAO-A breaks down dopamine, serotonin, and norepinephrine, and MAO-B breaks down mostly just dopamine. Just like tricyclics, these drugs are rarely used in the modern era anymore because of side effects. But years ago, there were three MAO inhibitors that were used to treat depression. They were tranylcypromine, phenelzine, and isocarboxazid. These were non-selective MAO inhibitors that inhibited both MAO-A and MAO-B. Nowadays, there is a drug sometimes used to treat Parkinson's disease. It's a selective MAO-B inhibitor, so it only boosts the levels in the brain of dopamine, and that drug is called selegiline. So in the modern era, the only place you'll really see MAO inhibitors used are for refractory depression, sometimes for anxiety, and as I said before, selegiline is a selective MAO-B inhibitor used in Parkinson's. Years ago, when MAO inhibitors were used more routinely to treat depression, these drugs were a cause of the serotonin syndrome. The serotonin syndrome is a clinical syndrome that occurs when patients have too much serotonin activity in the brain. And you can remember the clinical features by the three A's. So the first A is for agitation. That's because patients with serotonin syndrome have mental status changes. They're agitated, restless, and sometimes disoriented. The second A is for autonomic hyperactivity. These patients are sweaty, their heart is racing, and often their temperature is elevated. And then the last A is for neuromuscular hyperactivity. These patients have muscles that are going haywire, so they can have tremor, clonus, hyperreflexia, and if you perform the Babinski test, you'll often find a bilateral Babinski sign. The treatment for this syndrome is a drug called cyproheptadine. It's a serotonin antagonist. So like I said, years ago, when MAO inhibitors were more commonly used as antidepressants, they would sometimes lead to the serotonin syndrome. And the way this would happen is that a patient who is on a MAO inhibitor for depression would then take some other serotonin boosting drug, and that would lead to the serotonin syndrome. So what are some of the drugs or substances that, when taken together with MAO inhibitors, can lead to the serotonin syndrome? Let's talk about that now. These are all high yield for you to know for step one. So if a patient on a MAO inhibitor took another type of antidepressant like an SSRI or an SNRI, which we'll talk about later, or a tricyclic antidepressant, this could boost serotonin levels to the point that the serotonin syndrome would develop. Patients who abuse ecstasy, which is also called MDMA, this is a drug of abuse, this boosts serotonin levels, and that can lead to the serotonin syndrome in someone on a MAO inhibitor. Ondansetron is an antiemetic. It's used for nausea. It's a 5-HT3 antagonist, meaning that it blocks the subtype 5-HT3 receptor for serotonin. So why does this lead to the serotonin syndrome? Well, when you block this receptor subtype, that leads to more activity at the 5-HT1 and HT2 subtypes of serotonin. receptors, and that can potentially cause the serotonin syndrome. Tramadol is a weak opioid, but it also inhibits serotonin reuptake, so that can lead to the serotonin syndrome. Meperidine is also an opioid that inhibits serotonin reuptake. Triptans are drugs used for migraine headaches. They are serotonin agonists. Linezolid is an antibiotic that I talk about in the infectious disease section, and it has weak MAO inhibitory activity. So if taken together with a MAO inhibitor, this could lead to the serotonin syndrome. Dextromethorphan is a cough suppressant, but it also works as a weak SSRI. And then finally, St. John's wort is an herbal supplement that some people take for depression. And the way that it works is by increasing serotonin activity, and therefore that can lead to the serotonin syndrome. So because of the possibility of interaction between all of these substances and MAO inhibitors, there's usually a 2-week washout if you want to stop a MAO inhibitor and start some other drug that has serotonin boosting activity. So for example, when switching someone from a MAO inhibitor to an SSRI, you would stop the MAO inhibitor for 2 weeks, and then you could start the SSRI. So the serotonin syndrome was one reason that people stopped using MAO inhibitors once other antidepressants came available. The other reason was because of something known as the cheese effect. So let's talk about that now. Tyramine is a naturally occurring substance that is a monoamine. This is its structure on the screen here. It's got a benzene ring attached to a nitrogen group. If it gets into your bloodstream, it can act as a sympathomimetic and activate sympathetic nervous system receptors. Now, normally it's metabolized in the GI tract, so it doesn't get into your bloodstream, but it's metabolized by monoamine oxidase. So in patients who are taking MAO inhibitors for depression, if they eat foods that contain tyramine, tyramine could get into the blood, and this could cause a hypertensive crisis. These patients would develop headache or chest pain and have markedly elevated blood pressure. And this was called the cheese effect because there's lots of tyramine in cheese. There's also tyramine in red wine and some meats. So the classic scenario that you may still see in your board exams is a patient on a MAO inhibitor who goes out to dinner and has pizza and red wine and then comes in with hypertensive urgency. That patient is suffering from the cheese effect, and the cause is tyramine that was present in the food. Now let's talk about the next class of antidepressants, the selective serotonin reuptake inhibitors, or the SSRIs. As the name implies, these drugs inhibit the reuptake of serotonin by neurons, and this leads to increased serotonin levels in the synaptic cleft. These drugs have a slow onset of action, so when patients are depressed and you start them on an SSRI, you need to let them know that they're not going to notice the benefit the first day. It usually takes about 4 to 8 weeks to see effects. And there are a number of different SSRIs. I've listed all their names here in this box. And you should be aware that in addition to depression, they're also used in many other psychiatric disorders. They have some effect in generalized anxiety disorder, panic disorder, obsessive compulsive disorder, bulimia, social anxiety disorder, and PTSD. The main substance to see effects. And there are a number of different SSRIs. I've listed all their names here in this box. And you should be aware that in addition to depression, they're also used in many other psychiatric disorders. They have some effect in generalized anxiety disorder, panic disorder, obsessive compulsive disorder, bulimia, social anxiety disorder, and PTSD. The main weeks to see effects. These drugs have a slow onset of action, so when patients are depressed and you start them on an SSRI, you need to let them know that they're not going to notice the benefit the first day. It usually takes about 4 to 8 weeks to see effects. And there are a number of different SSRIs. I've listed all their names here in this box. And you should be aware that in addition to depression, they're also used in many other psychiatric disorders. They have some effect in generalized anxiety disorder, panic disorder, obsessive compulsive disorder, bulimia, social anxiety disorder, and PTSD. The main side effect of this drug that's a problem for patients is sexual dysfunction. This is believed to occur because of increased serotonin effects in the spinal cord. About half of patients will have a decreased libido, which means a loss of interest in sexual activity. And this can be a big problem if you're treating depression in a person who's married or a person in a long-term relationship. Another side effect is anorgasmia. People on these drugs have great difficulty achieving orgasm in a lot of cases. And this can be very frustrating. In addition, men often have erectile dysfunction when taking an SSRI. Other side effects are shown on this slide. Some patients develop GI upset because of GI serotonin effects. These are things like nausea, abdominal pain, and constipation. Some patients are drowsy on these drugs, and some patients gain weight. And then very rarely, there have been reports of serious side effects like SIADH or hyponatremia or QT prolongation, but this is relatively uncommon. Moving on, the next class of drugs are the serotonin norepinephrine reuptake inhibitors, or the SNRIs. And as their name implies, they inhibit the reuptake of both serotonin and norepinephrine, so they have effects on both neurotransmitters. These drugs also have a slow onset of action, just like the SSRIs, and they're used in many psychiatric disorders, also just like the SSRIs, not just depression, but also generalized anxiety disorder, social anxiety disorder, panic disorder, PTSD, and OCD. These are all things where SSRIs also have a role. In addition, one SNRI has shown some effectiveness in fibromyalgia, that's duloxetine, and venlafaxine has been shown to have some effect in diabetic neuropathy. And I've listed the names of the SNRIs in this box here on the screen. Because these drugs have norepinephrine effects, they can raise the blood pressure, and it's very high yield to remember that for board exams. A patient started on an SNRI who comes into clinic a few weeks later with hypertension may be having an adverse effect of the drug. Just like with the SSRIs, some patients on these drugs have nausea, although this usually gets better with time. And also, just like the SSRIs, some patients experience sexual dysfunction. The highest rate is seen with the SNRI venlafaxine. For the rest of this video, I'm going to talk about other antidepressants that don't really fit into one of the categories we've talked about up to this point. And the first drug I'll talk about is bupropion, which goes by the trade name Wellbutrin. This drug blocks the reuptake of norepinephrine and dopamine. It also increases the release of catecholamines, and it has no effects on serotonin. This is used in depression, and it's also used in smoking cessation. I talk about this in the video on stimulants, but there are data that smokers who take bupropion when they're trying to quit are more likely to quit. The thing you want to remember about this drug is that it's relatively activating, and it has the opposite effects of the SSRIs in many cases. So this drug can improve sexual dysfunction, and so it's often given together with an SSRI to cancel out the sexual dysfunction caused by the SSRI. It's also somewhat activating, so it sometimes cancels out the sedation that some patients develop on SSRIs. So a very popular combination to treat depression is an SSRI plus bupropion. The toxicity is related to the fact that it works on catecholamines and norepinephrine, so it has stimulant effects. So some patients on this drug can have anxiety, some patients have insomnia, and rarely, especially with older formulations of this drug, it's been reported to cause seizures. Our next drug is mirtazapine, which goes by the trade name Remeron. This drug blocks presynaptic alpha-2 receptors, and that leads to more norepinephrine and serotonin release. I'll show you a picture of how this works in a minute. In addition, in the postsynaptic neuron, this drug blocks two subtypes of the serotonin receptor, the 5-HT2 and 5-HT3 subtype. Because it blocks these two receptors, serotonin exerts more effect on the 5-HT1 subtype of receptors, and this is related to some of its beneficial effects. The thing you want to always remember about mirtazapine is that it has lots of antihistamine effects, and this is what causes its side effects. It's very sedating. It's often given to patients with depression who have trouble sleeping at night. They can take it right before bed. It also can cause a dry mouth, increased appetite, and weight gain. These are all antihistamine effects. Here's my own drawing about how the alpha-2 receptor blocking effects of mirtazapine work. So when a presynaptic neuron releases norepinephrine into the synapse, negative feedback is provided by norepinephrine acting on alpha-2 receptors. This tells the presynaptic neuron to stop releasing neurotransmitters. If you block this alpha-2 receptor with mirtazapine, then the negative feedback is blocked, and therefore more norepinephrine and serotonin are released into the synaptic cleft. The last three drugs I'm going to talk about in this module are among a class of drugs called serotonin modulators. These drugs inhibit the reuptake of serotonin just like SSRIs, but they also have properties as antagonists or agonists of some types of serotonin receptors. They have minimal effects on norepinephrine or dopamine. And the three drugs that are considered serotonin modulators are trazodone, vilazodone, and vortioxetine. Trazodone is a weak serotonin reuptake inhibitor, so in this way it functions like an SSRI, but it also has effects on two subtypes of serotonin receptors, the 5-HT2A and 5-HT2C receptors. At low dosages, it's a blocker of these receptors, but at high dosages, it's an agonist, and that's why it can be used as an antidepressant. Now, in the modern era, it's no longer used as an antidepressant because of side effects and because of better drugs that are available. Its main clinical use in the modern era is for insomnia. This drug is very sedating. It has strong antihistamine properties, so the one place you'll commonly see this used in the modern era is as a sleeping pill. Vilazodone blocks the reuptake of serotonin, much like SSRIs. It's also a partial agonist to a subtype of serotonin receptors called the 5-HT1A receptor. The main side effects of this drug are similar to side effects of SSRI. It can cause diarrhea in about a third of patients. It can cause sexual dysfunction, and there are case reports of patients taking vilazodone who develop the serotonin syndrome. Our last drug is vortioxetine. This blocks the reuptake of serotonin. It also has multiple properties on serotonin receptors. It's an antagonist of some subtypes of serotonin receptors and a partial or full agonist of other subtypes of serotonin receptors. It's unlikely they'll ask you about these specifics on your boards. The thing to remember is that this drug works on serotonin receptors. And the main side effect is nausea. Just like most serotonin drugs, it can cause GI upset. And that concludes our video on antidepressants. Hi, everybody, and welcome to our module on lithium. Lithium is a chemical element. You can find it on the periodic table right above sodium. It's also a cation, which means it is positively charged. And lithium was the first medical therapy that was ever determined to be effective for bipolar disorder. This happened in 1949. It's still used for bipolar disorder in some cases today. Now, lithium has many toxicities in a narrow therapeutic index, so patients who take lithium must have their serum level monitored and their dose titrated. If their lithium level is low, it means they are subtherapeutic and not getting the benefit of the drug. If their lithium level is high, it means there's an increased risk of toxicity. Even though lithium's been used for a long time for bipolar disorder, the mechanism is still incompletely understood. One thing that people have figured out that lithium does is it inhibits an enzyme called inositol monophosphatase. This enzyme is used inside of cells to regenerate inositol, and it's hypothesized that this may have to do with this mechanism, although how this leads to benefits for bipolar patients is unclear. But what happens when patients take lithium is that they have depleted levels of inositol inside of their cells. And inositol is used for a number of second messenger systems, so those levels of second messengers fall. In some other videos, I talk about second messenger systems for G proteins and other signaling systems in cells. Some of these include molecules like PIP2, IP3, and DAG. All of these involve inositol, so when the level falls in a patient on lithium, that is hypothesized to be one of the potential mechanisms of the drug's benefit. If you can remember that lithium is on the periodic table right next to sodium, it's very easy to remember many of lithium's features. Just like sodium, lithium is primarily renally excreted, and just like sodium, it's mostly reabsorbed in the proximal tubule like sodium, however, some goes out in the urine. And because of this mechanism of drug excretion, lithium is contraindicated in patients with significant renal impairment, although the drug can be used in patients with milder degrees of renal insufficiency. So risk factor drug excretion, lithium is contraindicated in patients with significant renal impairment, although the drug can be used in patients with milder degrees of renal insufficiency. So risk factors for lithium toxicity all make sense if you just remember that lithium behaves like sodium and it's renally excreted. So patients who have some degree of renal insufficiency and take lithium are at higher risk for toxicity. Patients who become volume depleted will filter less plasma and they're at increased risk for toxicity. And in addition, elderly patients have a higher risk of lithium toxicity. That's because the glomerular filtration rate normally falls as we get older. Lithium has a number of drug interactions, and these are all very easy to remember if you just remember that lithium is renally excreted, because all of these groups of drugs affect the kidneys. So drug classes that increase the lithium level and raise the risk for toxicity include thiazide diuretics, NSAIDs, and ACE inhibitors. And you should know if you've watched the renal videos that all of these groups of drugs affect the kidneys. So thiazide diuretics can decrease the GFR, NSAIDs can decrease renal perfusion, and ACE inhibitors can decrease the GFR. So it makes sense that all of these will lead to less lithium going out in the urine and a higher lithium level. And I've bolded thiazide diuretics because this is a classic board question. It appears on the STEP exams, on the internal medicine exams, and even the emergency medicine exams. A patient on lithium who has started on a thiazide diuretic for hypertension is a classic patient to develop lithium toxicity, and that's because thiazide diuretics raise the lithium level. Now, potassium-sparing diuretics are a special class of drugs. They affect the kidneys, but what they do is they decrease the lithium level, and we'll talk about why this happens later. And then finally, loop diuretics can increase or decrease the level. They have varying effects, and this is because they lead to volume depletion, but they also cause more lithium to go out in the urine. For the remainder of this video, I'm going to increase or decrease the level. They have varying effects, and this is because they lead to volume depletion, but they also cause more lithium to go out in the urine. For the remainder of this video, I'm going to talk about the adverse effects of lithium, and you can basically break these down into three groups. First are the acute effects, which occur right after a patient starts the drug. There's basically only one of these, and that's tremor. Long-term, patients who take lithium therapy are at risk for thyroid problems, kidney problems, and cardiac problems, and we'll talk about all of those. And then finally, mothers who take lithium during pregnancy place the baby at risk for fetal effects of the drug, and the classic one of these is Epstein's anomaly, and we'll talk about that as well. Tremor is a classic side effect of lithium therapy. It occurs when the drug is started or when the dose is increased. It's symmetric and it's usually limited to the hands or arms. A classic complaint of a patient newly started on lithium is to say that both of their hands are trembling. This usually gets better over time, and it's the most common symptom of lithium toxicity. So always remember this. This is something they're likely to ask you about on your boards. Patients who take lithium for long periods of time are at risk for thyroid problems. Lithium is a goitrogen, and I discuss goitrogens in the endocrine section in the videos on thyroid abnormalities. Goitrogens are substances that inhibit the release of thyroid hormone from the thyroid gland. For this reason, the thyroid gland is stimulated to produce more hormone, and this commonly causes a goiter, which is an enlarged thyroid. 40 to 50% of patients taking lithium have an enlarged thyroid. And in some cases, the lithium suppresses thyroid hormone production to such a degree that the patient can develop hypothyroidism. Lithium is a classic cause of nephrogenic diabetes insipidus. You will read in your textbooks that lithium causes a chronic tubulointerstitial nephropathy, and what this means is that the tubules in the kidneys become unable to concentrate the urine, and they do not respond to ADH. As a result, lots of free water goes out in the urine, and the urine is very dilute with a low urine osmolarity. Nephrogenic diabetes insipidus. You will read in your textbooks that lithium causes a chronic tubulointerstitial nephropathy, and what this means is that the tubules in the kidneys become unable to concentrate the urine, and they do not respond to ADH. As a result, lots of free water goes out in the urine, and the urine is very dilute with a low urine osmolarity. Because there's lots of urine being produced, the patient will complain of polyuria, and the polyuria will make them thirsty, so they will drink a lot and complain of polydipsia, meaning they're thirsty all the time. Now, in some cases, the loss of free water will increase the serum sodium. However, in many cases, patients drink enough to keep up with the free water loss, and in these cases, the serum sodium can be normal. So remember that a normal serum sodium does not exclude diabetes insipidus. In terms of treatment of nephrogenic diabetes insipidus caused by lithium, if you administer vasopressin, which is an antidiuretic hormone analog, you will see no response. In other words, no change in the urine osmolarity. And that's because this is a form of nephrogenic DI, and only central diabetes insipidus responds to vasopressin. The ideal treatment is to discontinue the lithium, but this is not always possible. Some patients with bipolar disorder really need the drug. And in those cases, you can use a diuretic called amiloride. Amiloride is a potassium spirit. In terms of treatment of nephrogenic diabetes insipidus caused by lithium, if you administer vasopressin, which is an antidiuretic hormone analog, you will see no response. In other words, no change in the urine osmolarity. And that's because this is a form of nephrogenic DI, and only central diabetes insipidus responds to vasopressin. The ideal treatment is to discontinue the lithium, but this is not always possible. Some patients with bipolar disorder really need the drug. And in those cases, you can use a diuretic called amiloride. Amiloride is a potassium-sparing diuretic, and it inhibits sodium channels in principal cells in the collecting duct called ENaC channels. And when these channels are inhibited, lithium entry into kidney cells is blocked, so the drug is not able to cause toxicity. Shown on this slide is a drawing from our video on nephron physiology in the renal section. In that video, I talk about the principal cells of the collecting duct. Those cells have a sodium channel called the ENaC sodium channel, which reabsorbs sodium from the urine, in other words, from the lumen of the nephron, and it brings the sodium inside the principal cell. Well, it turns out that this channel also reabsorbs lithium. So it brings lithium into the principal cells. And once inside, the lithium can cause toxicity. So if you give a patient a miloride, you block this channel, and therefore there is less lithium inside the principal cells and less toxicity. And this can improve nephrogenic diabetes insipidus. This is also the reason that potassium-sparing diuretics like amiloride cause lithium levels to fall. They block the reabsorption of lithium, so more goes out in the urine, and the serum lithium level will become lower. Lithium can potentially have a number of effects on the heart. One of the common ones is that it can suppress the sinus node. Remember that when the sinus node depolarizes, that generates the P wave on the EKG. So if a patient is taking lithium, they may have sinus node dysfunction. This can lead to bradycardia, pauses, and in some cases it can lead to syncope. Finally, I'll discuss maternal lithium. If a woman is taking lithium therapy for bipolar disorder and she becomes pregnant, the baby is at risk because lithium is a teratogen. It completely equilibrates across the placenta. Remember, it's just like sodium, so the baby is exposed to the same level as the mother. And the teratogenic effects in the fetus primarily involve the heart. The classic teratogenic effect of lithium toxicity is Ebstein's anomaly. I talk about Ebstein's anomaly in the cardiology section. Ebstein's anomaly involves apical displacement of the tricuspid valve. That means the tricuspid valve, which is normally found in the right ventricle at about this level, is displaced down towards the apex. And this often leads to tricuspid regurgitation and right heart failure. And that's the classic fetal adverse effect of a mother who takes lithium during pregnancy. And that concludes our video on lithium. Hello, everyone, and welcome to our module on antipsychotics. Let's start by talking about dopamine, which, as you probably know, is a neurotransmitter used in the central nervous system. In the 1950s, the drug chlorpromazine was found to improve psychosis, and then later it was also found to block dopamine receptors in the central nervous system. So this led to what's known as the dopamine hypothesis, which states that by blocking dopamine activity in the central nervous system, you can improve psychosis. And this is how many antipsychotics work. Chlorpromazine is just one of a number of drugs that came out many years ago and are called the first generation or typical antipsychotic drugs. All of these have some level of dopamine blockade in the central nervous system, and that's how they work. Haloperidol, which is also called Haldol, is still commonly used today. And these other drugs here are first generation or typical antipsychotics. Most of them end in azine. Most of these are not used that commonly today because, as we'll talk about later in this video, the second generation antipsychotics have less side effects. But nevertheless, these are the first generation or typical antipsychotics on this slide. The primary antipsychotic effect of the first generation antipsychotics comes through blockade of the D2 subtype of dopamine receptors. These are found on postsynaptic neurons in the central nervous system. You can find them in the limbic system, the basal ganglia, and the prefrontal cortex. They are coupled to G proteins, and there are two subtypes of dopaminergic neurons in the central nervous effect of the first generation antipsychotics comes through blockade of the D2 subtype of dopamine receptors. These are found on postsynaptic neurons in the central nervous system. You can find them in the limbic system, the basal ganglia, and the prefrontal cortex. They are coupled to G proteins, and there are two subtypes of dopamine receptors, the D1 and the D2 type. The D1 subtype activates adenyl cyclase and raises the intracellular level of cyclic AMP. The D2 subtype does the opposite. So if you look at the bottom of the screen, what adenyl cyclase does is it converts ATP into cyclic AMP, which looks a lot like ATP, except it's got a ring here attached to the nucleotide. So this is the normal role of adenyl cyclase, and it's normally inhibited by D2 receptors. So if you remove that inhibition, what will happen is the level of cyclic AMP inside of neurons will rise, and that's the effect of D2 blockade by first-generation antipsychotics. These drugs are sometimes called neuroleptics, which means a drug that depresses nervous system activity. They can be used in schizophrenia, although they're not used that often in the modern era. They're best at treating the positive symptoms, not the negative symptoms of schizophrenia. They're also used in other forms of psychosis, in mania and bipolar disorder, in OCD, in delirium, especially haloperidol is commonly used in the hospital to treat patients with acute delirium. And then finally, they can be used in Tourette syndrome and Huntington's disease. So the mechanism of action of first-generation antipsychotics is fairly straightforward to understand. It involves blockade of the D2 subtype of dopamine receptors in the central nervous system. What's more complicated about the first generation drugs are all the side effects. They have lots and lots of side effects, and this is what's usually tested on your exams. And this is what we're going to go through in the next few slides. In the neurology section, in our video on Parkinson's disease, I talk about how Parkinson's is a disorder of motor dysfunction where patients develop tremors and muscle rigidity. And in that video, I talk about how Parkinson's disease is associated with decreased dopamine activity in the central nervous system. And if you can remember this, then it's very easy to understand that once you start blocking dopamine receptors in the central nervous system with first-generation drugs, you are going to get lots of muscle symptoms, many of which resemble Parkinson's disease. Another thing to know about dopamine is that there are many other neurotransmitters that are also small molecules like dopamine, and they are also impacted by many of the first-generation antipsychotics. So for example, serotonin, which is also called 5-hydroxytryptamine or 5-HT, has a very similar structure to dopamine. So does histamine, so does epinephrine. Acetylcholine has a different structure, but it's still a small molecule active in the central nervous system. And some of these drugs also block acetylcholine, which means they block muscarinic receptors. So if you want to understand the side effects of all the first-generation antipsychotics, you just have to understand that all these neurotransmitters are small molecules similar to dopamine, and they will often be impacted as well as dopamine in patients who take first-generation drugs. So the goal of the first-generation drugs is to block dopamine, but many of these drugs also block the effects of serotonin, histamine, acetylcholine on muscarinic receptors, and epinephrine and norepinephrine on alpha-1 receptors. And the different drugs have different degrees of blockade of all the receptor subtypes. So for example, chlorpromazine blocks alpha-1 and serotonin receptors equally and to a greater degree than dopamine. Haloperidol, on the other hand, is famous for the most dopamine blockade. It also has some blocking effect on alpha-1, serotonin, and histamine as well, but not as much as dopamine. So the intended effect of the first-generation drugs is to block dopamine receptors and improve psychosis. But to understand the side effects that patients get, you need to understand the consequences of dopamine blockade as well as blockade of those other neurotransmitters we just talked about. So when you block dopamine receptors, although you may improve psychosis, you can cause a lot of side effects, and most of them are Parkinsonian or movement side effects. These are called extrapyramidal side effects, and we'll talk about these in detail in a minute. In addition, when you block dopamine, you take away the inhibitory effect of dopamine on the pituitary gland, and that can lead to elevated release of prolactin. So hyperprolactinemia can occur. And hyperprolactinemia in women can cause amenorrhea. It can also cause galactorrhea and gynecomastia. And then finally, blocking dopamine, it turns out, is actually effective for suppressing nausea and vomiting. So some of the antipsychotics of the first generation function as antiemetics. In particular, prochlorperazine and chlorpromazine are both sometimes used even today as anti-nausea drugs. When you block acetylcholine muscarinic receptors, you get problems like dry mouth and constipation, and these happen with some first generation antipsychotics. If you block alpha-1 receptors, this can lead to hypotension, and if you block histamine receptors, this can lead to sedation and constipation. So all of these are side effects you can see in patients taking these first-generation drugs, and it depends on which drug is used and to which degree it blocks each receptor subtype. I told you before that blockade of dopamine receptors can lead to movement side effects that are called extrapyramidal. So let me explain what I mean by that now. When we refer to the pyramidal system of the nervous system, we're talking about the cortical spinal tract, and it gets the name pyramidal system because the cortical spinal tract runs in the pyramids of the medulla. And if you damage this system, that will cause weakness. You won't be able to move your arms or your legs. The extrapyramidal system is the basal ganglia nuclei and associated tracts. This system is responsible for modulation of movement. And if you damage or inhibit this system, that will lead to movement disorders similar to Parkinson's syndrome. And this is what happens in patients who take first-generation dopamine blocking drugs. They get movement disorders that resemble Parkinson's disease, and those are called extrapyramidal side effects. So extrapyramidal symptoms or extrapyramidal side effects are related to dopamine receptor blockade in the central nervous system. They are movement side effects. And there are 4 types of extrapyramidal side effects you can see in patients on first-generation drugs. They are called dystonia, akathisia, bradykinesia, and tardive dyskinesia. And we'll go through each of these 4 in the next few slides. Dystonia is an extrapyramidal symptom that you can see in patients taking first-generation drugs. It occurs because of dopamine blockade, and it's an acute side effect. It can occur within hours or days of taking the drug. I've seen this in patients in the hospital just a few hours after a single dose of haloperidol. Dystonia means an involuntary contraction of muscles, so this symptom presents as spasms or stiffness. Patients will say they can't move their arm or their jaw is locked. This is a dystonic reaction to one of the antipsychotic drugs. The treatment for this is a drug called benztropine, and you can just think of benztropine as a drug that unfreezes muscles. That's basically what it does. It's an anticholinergic drug. It blocks amylin receptors, and this improves dystonia. And as we'll see, it's also used in some other extrapyramidal symptoms, but only in cases where patients are frozen, not in cases where patients are tremorous or shaking. It won't work in that situation because what it does is it unfreezes muscles. Our next extrapyramidal side effect is akathisia. This occurs within days of starting one of these antipsychotic medications. And among all the extrapyramidal side effects, this one is the most common. Many patients who take these drugs complain of akathisia. Akathisia is a sense of restlessness or an urge to move. Many patients will simply say they feel very jittery when they're taking one of these medications. In some cases, it's misdiagnosed as worsening psychotic agitation when, in fact, it's a side effect of the drugs. The treatment is to lower the dose of the antipsychotic medication if that's possible. Benzodiazepines can sometimes settle this symptom down, and the beta blocker propranolol is also used. Now, there are some limited data that say benztropine can be used in this situation, and you'll find that in some books, but you should be aware that benztropine is second line for akathisia as opposed to other extrapyramidal symptoms. And the reason for that is because, as we just talked about, benztropine unlocks muscles and helps muscles to move. And in general, that is often not helpful when patients are restless and already have an urge to move. But there are some limited data that it has some effect, so you will see that in textbooks. Bradykinesia is the third extrapyramidal side effect. This occurs within weeks after starting one of the dopamine blocking drugs. This side effect is sometimes referred to as drug-induced Parkinsonism, and that's because these patients have very slow movements, much like in Parkinson's disease. And in this situation, you can use benztropine, just like for dystonia. That's because, once again, here you have frozen muscles, muscles that won't move. That's why the patient's movements are slow, and that's why benztropine can be used. The last extrapyramidal side effect is tardive dyskinesia. This is also the worst of the four extrapyramidal side effects. The word tardive means late, and it gets this name because this side effect occurs months or years after starting a dopamine blocking drug, as opposed to the other side effects we've been talking about up until now, which start earlier than that. The key feature of tardive dyskinesia is something called choreoathetosis. So let's talk about what this word means. So chorea is an irregular migrating contraction. So patients will move their arms sort of in a snake-like motion. Athetosis means a twisting and writhing. So patients will often have these twisting and writhing irregular motions, usually of their mouth, tongue, face, or limbs. I've seen this in a couple of patients over my career. They're often smacking their lips or grimacing in a way that they just can't stop. They do this sort of like a nervous tic. And this is often irreversible. Even if you stop the drug, it won't help. And this is one of the main reasons that the first generation antipsychotics are no longer used for long-term therapy, because when you had to do that years ago, when these were the only drugs available, a percentage of patients would develop this side effect and have a permanent motor dysfunction because of the drug. For long-term therapy is sort of like a nervous tic. And this is often irreversible. Even if you stop the drug, it won't help. And this is one of the main reasons that the first generation antipsychotics are no longer used for long-term therapy, because when you had to do that years ago, when these were the only drugs available, a percentage of patients would develop this side effect and have a permanent motor dysfunction because of the drug. The first generation antipsychotics vary in their frequency of side effects. And I mentioned this earlier, how chlorpromazine blocks alpha-1 and serotonin receptors more than dopamine. Haloperidol, on the other hand, blocks dopamine the most, and these others less than dopamine receptors. One way the first generation antipsychotics are often broken down is into high potency and low potency agents. So the high potency agents are drugs like haloperidol, trifluoroperazine, and fluphenazine. These drugs are called high potency because they're very potent. It takes a lower dose to achieve the desired effect. For example, the typical dose of Haldol, which is another name for haloperidol, is only 1 milligram, a very small dose. And these high potency agents tend to have little effect on histamine and muscarinic receptors. So they have very little dry mouth, that's from muscarinic blockade, or sedation from histamine blockade. The main side effects of the high potency agents are extrapyramidal side effects, and that's because they're very strong dopamine blockers. Just like haloperidol shown in the bottom of the screen here, they tend to block dopamine receptors more than any other type of receptor. Low potency first generation antipsychotics are drugs like thioridazine and chlorpromazine, and they're called low potency because they're less potent. It takes a higher milligram dosage to achieve the effect. For example, thioridazine requires a dose of 50 to 100 milligrams compared to the 1 milligram dose of haloperidol we talked about on the last slide. And the thing to know about the low potency agents is that they tend to have less extrapyramidal side effects and more non-neurologic side effects. In other words, more of the non-movement related side effects. They tend to be sedating. These drugs are sometimes called sedatives, and they often cause dry mouth. In milligrams compared to the 1 milligram dose of haloperidol we talked about on the last slide. And the thing to know about the low potency agents is that they tend to have less extrapyramidal side effects and more non-neurologic side effects. In other words, more of the non-movement related side effects. They tend to be sedating. These drugs are sometimes called sedatives, and they often cause dry mouth. And years ago, if you were a doctor in the 1950s, before benzodiazepines and other drugs were available, these drugs, these low potency agents, were commonly administered to patients with agitation because they were sedating and they would calm them down. So you can think of these first generation agents as a spectrum. The low potency agents, like those over here, have lots of non-extrapyramidal side effects like sedation and dry mouth. The high potency agents, like those on the other end of the spectrum, tend to have more EPS or movement symptoms related to the drugs. All the side effects of first generation antipsychotics that we've talked about up until this point have involved blockade of some receptor type like histamine or dopamine. But now I'm going to talk about other side effects of the first generation antipsychotics, and these are effects that aren't related directly to one specific receptor type. And the first of these side effects is neuroleptic malignant syndrome, or NMS. This is a rare, dangerous reaction to neuroleptics, in other words, to antipsychotic drugs. It usually starts about a week after a patient starts taking one of these drugs. The mechanism of this adverse effect is poorly understood, but the key features are fever and rigid muscles. This is what you want to watch out for in a board question. If you see rigid muscles, you may be thinking of some extrapyramidal side effect, but if there is fever involved, you should think of NMS. In addition, the patient usually develops mental status changes. This is a form of encephalopathy, and there's also muscle damage, so creatine kinase levels will rise in the blood. You can detect these on a blood test. There can be myoglobinuria, which can lead to acute renal failure and rhabdomyolysis. The treatment is with dantrolene, which is a muscle relaxant, or bromocriptine, which is a dopamine agonist. And in the musculoskeletal section, in the video on skeletal muscle, I talk about malignant hyperthermia. That is a very similar clinical syndrome to NMS. Malignant hyperthermia is related to the ryanodine receptor. That's not the case for NMS. But malignant hyperthermia develops among patients who receive the anesthetic halothane or succinylcholine. It looks a lot like NMS with fever and rigid muscles, and it has the same treatment, which is dantrolene, a muscle relaxant. Some of the antipsychotics may prolong the QT interval. That's because some of these drugs have cardiac potassium channel blocking effects. And in the video on antiarrhythmic drugs, in the cardiology section, I talk about how drugs that block cardiac potassium channels usually prolong the QT interval. And if the QT interval becomes prolonged enough, it can lead to torsades de pointes, which is a life-threatening cardiac arrhythmia. And among all the antipsychotics, the one that's famous for doing this is IV haloperidol. And in the video on antiarrhythmic drugs, in the cardiology section, I talk about how drugs that block cardiac potassium channels usually prolong the QT interval. And if the QT interval becomes prolonged enough, it can lead to torsades de pointes, which is a life-threatening cardiac arrhythmia. And among all the antipsychotics, the one that's famous for doing this is IV haloperidol. Some of the antipsychotics can have ocular or eye side effects. These usually aren't seen in the modern era, but years ago, when patients took first-generation antipsychotics for long periods of time, some of these ocular effects could develop. Chlorpromazine begins with a C, and that can help you remember that it may cause corneal deposits. Remember, the cornea is in the front of your eye, and that's where you'll see these deposits. And in some cases, this used to accelerate the aging of the lens in patients on this drug. Thioridazine has an R in the middle of the name, and that can help you remember that it leads to retinal deposits. Remember, the retina is in the back of the eye, so deposits can form there. In some cases, it would look like retinitis pigmentosa. This is a picture of retinitis pigmentosa shown on the screen here. This is a disorder caused when children have loss of rods and cones, but you can see similar features in patients who have thyroidazine complications. What patients used to complain about when they got this side effect was browning of their vision. And years ago, when doctors prescribed thyroidazine long-term, they would use a low dose to avoid this side effect. Now we're going to move on and talk about the second generation or atypical antipsychotic drugs. And just like the first generation drugs, these drugs also have properties whereby they block dopamine receptors and histamine receptors and other receptors to varying degrees depending on the drug. The main difference between the second generation drugs and the first generation drugs is that the second generation drugs have far fewer side effects, and in particular, they have a much lower rate of extrapyramidal adverse effects. And that's why these drugs are much more commonly used for chronic therapy of conditions like schizophrenia in the modern era, because patients are much less likely to develop extrapyramidal side effects and other side effects. Most of the second generation drugs end either in apine or idone. The one exception is a drug called aripiprazole, which we'll talk about at the end of this video. One thing to know about the second generation antipsychotics is that many of them have significant serotonin receptor blocking effects. So years ago, people were studying LSD, which is lysergic acid diethylamide. It's a drug of abuse that I talk about in substance abuse videos. And people figured out that one of the reasons LSD makes you hallucinate is because it activates serotonin receptors. In particular, they found out that the 2A subtype of serotonin receptors was responsible for many of the hallucinations caused by LSD. Later, people studied the atypical or second generation antipsychotics and found that many of these drugs significantly block the 2A subtype of serotonin receptors. And in fact, many of these drugs are as or more effective serotonin blockers compared with dopamine. So for example, if you look at the bottom of this slide, two second generation drugs are shown here, clozapine and olanzapine. So clozapine blocks alpha-1 receptors more than serotonin, but it blocks serotonin more than dopamine, and this is typical of the second generation agents. Olanzapine blocks serotonin more than histamine and dopamine, and it blocks alpha-1 receptors the least. But this pattern of more serotonin block compared to dopamine block is seen among many of the second generation agents, and this is believed to be why they're better at reducing psychosis without causing as many side effects as the first generation drugs. So these drugs are commonly used in schizophrenia. They're the mainstay of treating schizophrenia in the modern era. They've been shown to improve both positive and negative symptoms, and this is in contrast to the first generation agents, which only help with positive symptoms. They're also used in bipolar disorder, OCD, anxiety disorder, depression, and Tourette syndrome. These drugs have some special side effects, which we'll talk about in a minute, but just like I said before, it's important to remember that the reason these drugs are so popular compared to the first generation agents is that they have fewer extrapyramidal side effects and also fewer anticholinergic effects. Another thing to know about these drugs is just like the first generation agents, they still can prolong the QT interval. So what are some of the special side effects of the second generation agents? The first one is metabolic syndrome. Now this can occur with any antipsychotic. However, it is most common with two second generation agents, clozapine and olanzapine. And the metabolic syndrome refers to weight gain, hyperglycemia, and hyperlipidemia. This triad happens to a lot of people with schizophrenia who have to take these drugs. And it's very unfortunate. They become very overweight and they can develop high cholesterol and diabetes. And it's all related to the therapy they have to take for their schizophrenia. Clozapine has some special side effects you should be aware of. It's potentially toxic to the bone marrow. In 1% to 2% of patients, it causes agranulocytosis, which makes patients prone to dangerous infections. For that reason, any patient that takes this drug has to get a white blood cell count every week at the start and then every few weeks to every month thereafter to make sure they don't develop this side effect. It's reversible when the drug is stopped, so if you pick it up before the patient's white blood cells plummet and before they get an infection, then you can stop them from getting sick. In addition, up to 5% of patients in some studies have seizures on this drug. It's dose-related, but this is another potential side effect. So it's high yield for your board exams to know about agranulocytosis and seizures for patients on clozapine. Next, let's talk about hyperprolactinemia, which I discuss in detail in the endocrine section in the video on the pituitary gland. Antipsychotic drugs are the most common drug-induced cause of hyperprolactinemia. It's high yield to remember that. And that's because all these drugs have some dopamine blocking effect, and dopamine suppresses prolactin release from the pituitary gland. So when you block dopamine, you get increased prolactin release. This will present as amenorrhea in women, it can present as gynecomastia in men, and it can also present with galactorrhea. So basically, anytime you see these three things, you measure a prolactin level. And if it's elevated, the first thing you want to do is scan the head to make sure the patient doesn't have a pituitary adenoma. Once you scan the head and you find it's normal, the next thing you want to do is look at their med list, because there are lots and lots of causes of medication-induced hyperprolactinemia. And among all those causes, antipsychotics are the most common. The highest rates are seen with these 4 drugs I've shown here. Now, patients in the modern era usually are not prescribed first-generation agents like haloperidol or fluphenazine for long periods of time. So you rarely see a patient walk in who chronically takes one of these drugs and has high prolactin levels. But the second-generation agents are prescribed for long periods of time, and 2 of those drugs, risperidone and paliperidone, are commonly associated with high prolactin levels and hyperprolactinemia. I'll finish with this slide on aripiprazole, which has an unusual mechanism of action among the second-generation antipsychotics. Aripiprazole is a partial agonist of D2 receptors, so it has some blocking and some agonist effects. And the idea here is that with less dopamine blockade and some agonist effects, you may see less dopamine-related adverse effects. That's the goal of this drug. The most common side effect of this drug is akathisia, and that's easy to remember because I told you earlier that akathisia, or restlessness, is the most common of all the 4 extrapyramidal side effects. It's also the most common side effect of patients on this drug. And that concludes our video on antipsychotics.